So, welcome to the next in a series of lectures. This one talking about the hand and wrist. I'm Henry. I'm one of the radiology registrars working at SA Medical Imaging. So, looking at the learning objectives, today's talk hopes to explain the utility of various imaging modalities in imaging the hand and wrist, and more specifically, looking at the fractures that occur around the hand and wrist and some of the named fractures, the dislocations. We'll have a quick talk on AVN and Kienbock's disease and ganglion cysts as well. So to do that, we'll have a quick look at anatomy first, then talk about wrist and carpal fractures, carpal instability and dislocations, finger fractures and dislocations, and some tendon injuries and inflammatory conditions about the hand and wrist. So that's a number of bones around the hand and wrist. There are also a number of different mnemonics people use to memorize the order of the carpal bones. My preferred is so long to pinky, here comes the thumb, as it tells you exactly what order they go in as well. So long to pinky, scaphoid, lunate, triquetrum, pisiform, here comes the thumb, hamate with its hook, capitate, trapezoid and trapezium, and I always remember trapezium is under the thumb for what it's worth. And then we have 5 metacarpal bones. The digits 2 through 5 have proximal, middle and distal phalanges, and the thumb has a proximal and distal phalanx. On radiographs, this is much the same. So we're seeing radius and ulna. We've got the ulnar styloid and the radial styloid here. Scaphoid, lunate, triquetrum. We've got the hamate, the capitate, the trapezoid and trapezium, and we're not seeing the pisiform particularly well, although it's probably overlapping with the trapezoid over here. And then we've got the metacarpal bones. We have a few sesamoids around the hand, so sesamoid here and here, but they're very variable. We have the proximal, middle, and distal phalanges. We've got the tusks of the phalanges as well. Then we've got the carpometacarpal joints, the metacarpal phalangeal joints, the interphalangeal joint, and the distal and the proximal and distal interphalangeal joints. Oblique imaging is much the same, and this is just a bit more of a dedicated look at the wrist in a frontal projection and in a lateral projection, and it's important to see how the capitate and how the lunate and the radius articulate, important in lunate and perilunate dislocations. Pisiform sits more on the palmar aspect of the hand. The carpal arcs describe the alignment of the carpal bones on the frontal projection. So the first carpal arc is the curve outlining the proximal convexities of the scaphoid, lunate, and triquetrum. The second traces the distal concave surface of the same bones, and the third, the main proximal curvatures of the capitate and hamate. And disruption to these arcs can indicate either ligamentous injury or fracture. So these are the sort of named fractures that we'll be talking about around the wrist. But before we do that, there are a number of things that we can look for when we're assessing distal radial fractures, or when we're assessing the wrist at all, in terms of the radial radius and ulnar alignment. First is the radial height, where 2 lines are drawn perpendicular to the radial shaft along the articular surface and along the radial styloid, the tip of the radial styloid. We can look at the height between those. If there's height loss, we can think about an impacted fracture. Radial inclination is an angle of the distal radial surface with respect to a line that's drawn perpendicular to the shaft, and can be looked at for relative indications for operative management of distal radius fractures. Volar tilt can be described, or is the angle of the distal radius with respect to a line drawn perpendicular to its shaft, and is just a way of describing dorsal or volar angulation. And ulnar variance is probably the one that we most commonly discuss, which is the height of the ulna with respect to the radial articular surface. And it's described as either neutral, positive, or negative, depending on, and it sort of depends on several factors, including positioning. Another thing to look for around the wrist that might clue you into a sort of an occult fracture is a pronator quadratus fat stripe. So the pronator quadratus sits on the volar aspects of the wrist, and it's usually a radiolucent or a lucent stripe that's quite thin and pretty straight along the wrist there. Displacement or anterior bowing of the stripe can indicate a distal radius or ulnar fracture. So a Colles fracture is a fracture of the distal radius with dorsal angulation or displacement of the distal radial fragment, and patients present with a sort of characteristic dinner fork deformity at the wrist. So on X-ray we can see that there's a comminuted distal radial fracture. It's intra-articular and has dorsal angulation. So a Smith's fracture is a distal radial fracture with volar rather than dorsal angulation, and there are a few types that we can talk about. But here we can see that there's fractures of the distal radius and ulna with volar angulation, consistent with the Smith's fracture. A Barton's fracture is an intra-articular fracture of the dorsal margin of the distal radius. Which you can see here. And a Chauffeur's fracture is a fracture of the styloid process of the radius. Again, intra-articular fracture of the styloid process of the radius. An ulnar styloid fracture is pretty commonly seen and associated with distal radial fractures. So here we've got a fracture of the ulnar styloid, but we've also got an intra-articular fracture of the distal radius with dorsal angulation. And there are a number of fractures we can see of the carpal bones. Most commonly we see scaphoid fractures. Occurs in men more than female, and the mean age of 25 years old usually is the result of the fall of the fall on the outstretched hand. A lot of them are initially occult radiographically, and if untreated, there's a risk of avascular necrosis of the proximal pole due to how the scaphoid gets its blood supply. You'll see that despite some of these being radiographically occult, a lot of them will be treated as if they are scaphoid fractures with repeat imaging. Clinically, scaphoid fractures present with tenderness in the anatomical snuff box or of the scaphoid tubercle, or pain on longitudinal compression of the thumb. The majority of the scaphoid fractures occur at the waist of the scaphoid, and dedicated scaphoid views are performed which elongate the scaphoid. If there's clinical suspicion of a scaphoid fracture, because some can be radiographically occult, immobilization and reimaging in 7 to 10 days is often done in those where we're still a little bit suspicious. An MRI can be diagnostic. So here we've got a scaphoid series, and we can see that there's a fracture through the waist of the scaphoid here. and can often be only apparent on one view of your series as well. Like I said, there's a risk of avascular necrosis. We can see that there's, here we've got pretty subtly increased sclerosis of the proximal pole of the scaphoid, which is concerning for avascular necrosis. This is what it looks like on CT, and again, you've got a little bit more sclerosis in that proximal scaphoid, proximal pole of the scaphoid. And MRI, we can see that this X-ray doesn't look like the scaphoid fracture at all. MRI very helpful at detecting radiographically occult scaphoid fractures. So I've touched on some of the complications of scaphoid fractures. As with any other fracture, non-union or malunion is a complication. Avascular necrosis is a complication to be aware of, and that's because of how the scaphoid gets its blood supply. But one of the reasons that scaphoid fractures are so important to diagnose is if they're left untreated or there's non-union, there's the function of the scaphoid within the carpal bones is disrupted, and there can be unstable motion of the fracture side, leading to pseudoarthroses and non-union. And this can cause sort of secondary arthroses, and ultimately can lead to something called scaphoid non-union advanced collapse, which is a sort of pattern of arthritis where there's degeneration and ligamentous instability, which leads to rotary subluxation of the scaphoid, and it's similar to something called scapholunate advanced collapse, but associated with a scaphoid fracture. So this is scaphoid non-union. We can see that there's the distal and proximal poles of the scaphoid, and there's no bony union between the two. Avascular necrosis, we've touched on this before, but we've got a sclerotic proximal pole, and this can lead to further collapse down the line. And then SNAC, or scaphoid non-union advanced collapsed, where there's arthritis and subluxation from non-union of a scaphoid fracture, and then you can have rotary subluxation of the scaphoid, abnormal radioscaphoid contact, and early arthrosis. Triquetral fractures, the second most common carpal bone fracture, can result from a fall on an outstretched hand, impingement, where there's impingement of the ulnar styloid, and shear forces or revulsion from ligamentous attachments. There's also usually dorsal avulsion of the attachment of the radiocarpal ligament, and it's best seen on a lateral projection on plain films, but CT and MR are more sensitive. So here we can see a fracture of the triquetrum here. Difficult to see on frontal projection, but more easily seen on lateral projection. Hamate fractures can occur from a fall on an outstretched hand, or can be seen as stress fractures in some occupations, and usually we need CT or dedicated carpal tunnel views to diagnose these. So on frontal projections, it's small fracture line through the hamate here, more appreciable on lateral projections, but on dedicated carpal tunnel views, more easily seen, particularly on CT, where we can see there's a fracture through the base of the hook of hamate. Kienbock's disease is a term for avascular necrosis of the lunate bone. It's more common in the dominant risk of young men due to repeat loading on the lunate, which interrupts its vascular supply and can lead to fragmentation and collapse. Plain films show a sclerosis and flattening of the lunate bone, but MR is more sensitive. So here we can see that the lunate appears flattened and more sclerotic. There's a style classification which classifies the disease on the basis of radiographic changes. Stage 1, normal radiograph. Stage 2, increased density of the lunate with maybe a bit of lunate height loss on the radial side, which we're seeing here, to stage 3, where there's starting at the beginning of lunate collapse and rotation of the scaphoid, and then stage 4, progressive collapse and degenerative changes. Carpal bone instability is a pretty complicated topic. You can have either instability in dorsiflexion or volar flexion, and they're termed dorsal intercalated segment instability or volar intercalated segment instability, respectively. The intercalated segment refers to the proximal carpal row, which is identified by the lunate, and it refers to it as being the part between the proximal segment of the wrist, which is the radius ulna, and the distal segment, which is the distal carpal row. Generally, this is caused by either axial compression or hyperextension, falls on outstretched hands, or inflammatory arthritides like arthritis. So here we can see the dorsal intercalated segment instability, where there's dorsiflexion at the proximal carpal row, or volar, where there's volar flexion at the proximal carpal row. Dorsal intercalated segment injury is due to a disruption of the dorsal intercalated segment, which we talked about, and radiographically on lateral radiographs of the hand, the lunate is angled dorsally. Here we can see a DISI pattern with the lunate being dorsally tilted, and the lunate being dorsally tilted and the scaphoid being volarly tilted. Easier to see on MR, where there's dorsal angulation of the lunate relative to the radius and the capitate. Volar intercalated segment instability is less common than dorsal, except in rheumatoid arthritis, where volar is more common, due to disruption of the radial carpal ligaments on the ulnar side of the wrist, and is again identified by volar rotation of the lunate and dorsal rotation of the capitate and hamate. So we've got, again, volar tilt of the lunate, and the capitate is dorsally tilted. So there's a continuum of perilunate injury ranging from disassociation to dislocation, usually due to a fall onto an extended hand, and it's talked about in sort of 4 stages. Each of them progress from radial to ulnar side, and it indicates increased instability. So the stage 1 is scapholunate dissociation. So scapholunate dissociation refers to the result of rupture of scaphoid ligaments with a greater than 3 mm gap between the scaphoid and the lunate on frontal projection, and has been termed the Terry-Thomas sign. This is Terry Thomas. I'm too young to know who he is, but it's because he had a gap in his front teeth, so Terry Thomas sign. I think some people also refer to it as the Madonna sign. Perilunate dislocation is where you have the capitate dislocated dorsally and the lunate retained its normal articulation with the radius. So we can see here on the schematic the radius, the lunate with the capitate displaced dorsally. And that's what we're seeing here. So radius, lunate with the capitate dislocated dorsally. So stage 3 in the perilunate instability is a mid-carpal dislocation. It can be a little bit confusing because some people sort of describe this perilunate or lunate dislocations as mid-carpal dislocations, but in the context of sort of perilunate instability, there's mid-carpal dislocation represents stage 3, which is a rupture of the triquetral ligaments, where there is dislocation of the capitate from the lunate and the lunate subluxes from the radius. And then a lunate dislocation where the lunate dislocates volarly and the capitate appears aligned with the radius. So there are a few specific fractures of the fingers that Ben mentioned. Some particular first metacarpal fractures like a Bennett and Rolando, Box's fracture, gamekeeper's thumb, and then talk about some avulsion injuries as well. So a Bennett fracture dislocation is an intra-articular two-piece fracture of the base of the first metacarpal, and is a result of forced abduction of the thumb. So we can see an inter-articular fracture of the base of the first metacarpal, and it's two pieces. A Rolando fracture is a comminuted intra-articular fracture of the base of the first metacarpal, so more than three or more fragments, I should say, and usually due to an axial blow to a partially flexed metacarpal, i.e. punching. A Box's fracture is a fracture of the neck of the fifth metatarsal, usually with volar angulation and external rotation, again also due to punching, hence the name. So we can see there's a fracture of the neck of the fifth metacarpal with volar angulation. A gamekeeper's thumb or skier's thumb is results from an avulsion or rupture of the ulnar collateral ligament at the first MCPJ, and it can be associated with a sternal lesion where the ulnar collateral ligament is completely torn and displaced superficial to and proximal to the adductor pollicis, which prevents the UCL from returning to its normal position, but you need MRI to see that. So we can see there's an avulsion fracture of the base of the proximal phalanx. And MRI demonstrates rupture of the ulnar collateral ligament and bone marrow edema. Avulsion fractures are as the result of hyperextension with avulsion of the at the flexor digitorum superficialis insertion. And that's this little fracture here. Mallet finger is a avulsion injury of the extensor digitorum insertion, and you get a characteristic fixed flexion deformity at the distal interphalangeal joint. So this involves intra-articular fracture of the base of the distal phalanx. So boutonniere deformity is a combination of a flexion at the proximal interphalangeal joint and extension at the distal interphalangeal joint, usually related to an inflammatory arthritis, like rheumatoid arthritis. However, can be also be due to the tendinopathy or rupture of the central slip of the extensor tendon off the base of the middle phalanx. So we've got flexion at the PIP and extension at the DIP. This is as opposed to a swan neck injury, which can be as the result of an avulsion injury or a volar plate avulsion injury at the base of the middle phalanx, where there's hyperextension of the PIP and flexion at the DIP. I won't go into flexor tendon injuries too much, other than to say the zone of injury determines what sort of surgical approach is required, and they're broken up as such. and the thumb has its own zones. So at the wrist, the ulnar nerve passes through through Guynon's canal, or the ulnar canal, which is a fibro-osseous canal at the ulnar aspect of the hand, extending between the pisiform and the hook of hamate. And compression of the ulnar nerve at this point can lead to symptoms of pain and altered sensation in the ulnar 1.5 digits, weakness in flexion, abduction, and opposition of the 5th digit, and weakness in adduction and abduction. Ulnar nerve entrapment can be associated with ganglion cysts or repetitive trauma, and ultrasound might be helpful in demonstrating ganglion cysts or soft tissue tumours that could be causing entrapment. So ganglion cysts are non-malignant synovial cysts that occur in association with a tendon or a joint, most commonly seen in the hand and wrist. More commonly also in young women, and can cause a myriad of symptoms depending on their location due to mass effect on other structures. Some patients will have a history of trauma to that region. Histologically, they're made up of a thin connective tissue capsule containing mucinous material. They can occur within muscles, in menisci, associated with tendons or with bones, and like I said, most commonly in relation to the hand and wrist, mostly on the dorsum of the wrist. They can be classified based on their relation to bones or joints, so whether they're within bone, adjacent to, away from bone, or whether they're within or adjacent to a joint. On ultrasound, the vast majority are hypoechoic or anechoic with very well-defined margins, though some have some internal septations and acoustic enhancement. MRI is usually seen as a rounded or lobular fluid signal mass adjacent to a joint or a tendon sheath. So on ultrasound, as I've discussed, very well-defined, rounded, smoothly marginated with internal septations, hypoechoic or anechoic, and in relation with the joint. And on MRI, lobulated fluid signal, again in association with a joint. And that's all for the wrist. Thank you.